let's talk about the DS-8201. And so again, we're all talking, this is the decade of the ADC, I think. I think these, you got this, you know, we got all the TROP2 stuff with sacituzumab now. We're going to probably have SYD95, bispecific antibodies. There's going to be all sorts of cool stuff coming out. So Virginia, what is your take on DS-8201, the phase 2?
You're looking at the data, you see a little over 60% response rate in relatively heavily pretreated patients. But when you look at that waterfall plot, I think there were like 3 patients that had a little bit of an increase in their tumor volume, and everybody else had a decrease in their tumor volume. So pretty impressive data, but it comes at a price. There's over 10% rate of pneumonitis, several deaths. So definitely not a benign drug. A little more toxic as far as I've seen than TDM1, and you know, just people not feeling as well. TDM1, most people besides a little bit of neuropathy barely know that they're taking something. DS-8201 is a little bit worse than that.
Mm-hmm. Comments on DS-8201, Mark? What do you think?
I mean, the nausea we've seen within our group it tends to be delayed nausea, so you have to warn patients to be prepared for that and make sure they have scripts at home to accommodate it. Alopecia, you have to warn them about alopecia as well. So it's got toxicities very much like a topo-1 inhibitor chemo drug, you know, not as bad as irinotecan or topotecan, but the same types of toxicities, albeit at a little bit lower level, but you have to be prepared to co-medicate, dose adjust, et cetera. Fatigue is another feature you have to worry about, so as well as cytopenias. So, you know, it's real chemotherapy. It just happens to be linked to an antibody. Yeah.
But I mean, I guess I'm very impressed by this. I mean, the trials clearly, you know, are going to come out. I mean, can anybody put any more, you know, they had the trial, and I gave Daiichi a real hard time about this because they basically, it still is a trial of DS-8201 versus Cape Traz, you know, and I'm like, guys, everybody's already had Cape Traz already. Why are you doing this? You know, but I understand now why they did it, because it's a control arm of HER2 Climb. I don't think they knew that when they did it, but it actually will be a very nice comparison. But you think we can get that done anymore in the United States? I don't think we can get that done anymore. I think it's not going to, it's all going to be ex-US.
Right, not with the advent of the HER2 Climb data.
Yeah, we're just not going to be able to get that trial done. You know, not only that, but on the DS-8201 side as well. So is there a particular patient you have in mind for DS-8201 versus, because this is a question everybody just wants to know, do you have a patient in mind for DS-8201 versus Tucatinib? Is there a particular person that you would treat one way or the other? Carrie, we'll start with you and then we'll go around the table.
Sure. So I think, you know, I do think the status of the CNS disease matters because, as Virginia said, you know, the evidence that we have in progressive brain metastasis is much higher level with randomized data for HER2 Climb. And so if I have a patient who presents with metastatic disease, extracranial, yes or no, but progressive CNS disease, I'm going to reach for the HER2 Climb regimen. In the setting of stable brain metastasis, I think it would be a discussion with the patient. You know, I think sort of seeing what their prior toxicities have been, their compliance with oral therapies. I completely agree. Giving trastuzumab deruxtecan is not like giving TDM1, and I think it's really important for us to warn our patients about that, because I have also seen the fatigue and the nausea in my patients who've had trastuzumab deruxtecan. So I do, you know, I also think that the response rate matters as well. The 60% response rate in the Destiny-01 study was quite impressive. All those patients had received TDM1. So I might, if I had someone who was near visceral crisis, maybe with liver disease, I might favor the DS-8201 over the HER2 Climb regimen that had about a 40% response rate. So those would be some of the things that would be going through my mind in making that decision.
Well, before we go to someone else, I'm going to ask you, being the brain mets expert, what do you think of the data that was presented from Carson, also from, I think someone presented, it was Carson Decker or someone presented it, about the brain mets in Destiny?
For Destiny, so I think it's really interesting, and I think we just need more data. So I think there were 180 some patients in Destiny-01, of which 24 had brain metastasis. And their PFS was very similar to what we saw in the non-brain metastasis population, all of the patients in DS-8201 were deemed stable at the time of entry, not progressive.
Unstable,
Yep.
right? Yeah.
And when you look at the subset analysis for the CNS disease, there were very few CNS events as the site of progressive disease. I think of the 48 patients who progressed on the study globally, only 4 had CNS events, and there were documented responses in the brain. I think we just need more data there. I think we need a study that's dedicated to CNS response rate, intracranial PFS, and such before we know more.
Got it.
But I think it
Mark,
has great potential.
got it. Mark, what do you think?
For the non-brain metastasis patients, I'm very impressed by DS-8201. And albeit, you know, it has some toxicities, these are very manageable. We're all oncologists. We're used to dealing with all these side effects. They're very routine. They all can be mitigated with dose modification or co-medication. So I have no hesitation to give the drug in those patients. So given its extraordinary efficacy and duration of response in DS-8201, it's unbelievable. I mean, it's just very impressive.
Months. I mean, it's
For me, I would use 8201. That said, I'll give a balanced discussion of both possibilities with patients because, you know, the Tucatinib HER2 climb regimen is not without toxicity either. Diarrhea, PPE, nausea, vomiting, fatigue, hepatotoxicity, stomatitis, headache, anemia, and rash. I mean, all those are mitigating factors for that regimen as well. So I think a balanced discussion is appropriate. But if the patient says, well, what would you do, doctor? I would take 8201.
Virginia, what do you think?
I agree. And the good news with Tucatinib is that it works in progressive brain mets, which we don't have any data from any of the other agents. So I feel very comfortable giving DS-8201 for the patients that have stable brain mets. And when they progress, now I have a great option to give them.
So, Rashmi, I mean, I know your answer because you're the PI of the trial, but I have to ask you anyway. What would you do?
Yeah, no, you know, I think that the Destiny data is very striking. I mean, that was probably one of the most impressive lots that, you know, many of us have seen in across oncology trials. And so, you know, certainly I think for patients without brain metastases, you know, I would give strong consideration for use of DS-8201. The toxicities, you know, I saw some of the toxicities in patients who were trials as well, like the nausea and the hair loss and the fatigue. But, you know, as Mark pointed out, they are manageable. And so I think that that wouldn't make me shy away from use of the drug. Now, the one toxicity that I think is of concern is the ILD and pneumonitis. And so I think we definitely need to heed caution and consider it carefully in patients who have any kind of underlying pulmonary issues. But outside of that, I think, you know, this presents a really great option for our patients, especially those who have a systemic burden of disease and in whom we need to achieve a quick, rapid response. I'd certainly be pushed to use the DS-8201. And for patients with brain metastases, I think still my go-to choice would probably be Tucatinib, just given the response rates that we've seen in the brain and the survival benefits in those patients.